Good morning, good afternoon, good evening. I'm honored to welcome you all to one of the most exciting webinars hosted by the PPH Community of Practice. My name is David Nhirushwa. I'm the PPH Community of Practice co-chair. Our community regularly organizes series of webinars that aim to share this and disseminate the most updated knowledge, strategies, and implementation success and the challenge to the global maternal and newborn health community from all corners of the world. I want to thank our audience today, which is really made of various and diversity of people who are really dealing with maternal and newborn health. I also want to thank our most exciting and fantastic team of experts who are now going to be talking to us about one of the most updated updates, which is really, we are sure that is going to have an impact on the way we manage postpartum hemorrhage, but also have an impact on the reduction of women who are unfortunately suffering and dying, losing their life because of postpartum hemorrhage. We believe that the message and the knowledge shared is now going to reach many individuals, many women around the globe who really need it. So without further ado, I want to really now to start by introducing our experts, but mainly I'm going to invite our chief moderator, Dr. Jeffrey Smith, who is the Deputy Director of Maternal, Newborn and Child Health at the Bill and Melinda Gates Foundation. He's an obstetrician and gynecologist and global health strategist with 25 years of clinical and public health experience in developing countries across Asia, Africa, and Latin America. Smith, without further ado, I really want to invite you to take us through these exciting 90 minutes ahead. Thank you, and over to you, Smith.
Brilliant. Thank you very much, David. Good evening, good afternoon, and good morning to everybody from Seattle. I've heard that we have more than 900 people registered for this webinar. So I think that is not only a testament to everybody's concern for the issue of postpartum hemorrhage, but also everybody's curiosity and enthusiasm for the results of this very important study. Back in 2017, so about 6 years ago, WHO and the Gates Foundation convened a technical consultation about the use of bundles in addressing postpartum hemorrhage. And at that time, the idea of a bundle was adopted. But honestly, it was adopted recognizing that the idea was good, but in fact, we did not have evidence. We didn't really understand if a bundle versus individual components would be better. And at the foundation, we had a number of conversations and we started asking ourselves, if there's going to be a recommendation to the world to use all of the interventions to address postpartum hemorrhage, this group of interventions all at once for every case of postpartum hemorrhage, we really should have some better and stronger evidence that this is superior to sequential management. I see there's a question in the chat, in the Q&A box already. What is a bundle? Typically, in clinical management, a bundle is defined as a group of interventions that are all given at the same time by the same, typically by the same person, or a small group of people, but given all together in order to address a specific problem. And so the PPH bundle, and I think our colleagues will define the components of the bundle, but we needed to really understand, is this better? I think many of you, I'm an obstetrician, there are many providers, there are midwives, there are practitioners and managers on this. Many of you are looking at whether the typical management of sequential interventions. And so I think what we're going to see today is the evidence about using a bundle and whether or not that actually improves care. I want to turn things over to our expert panelists. But first, a bit of housekeeping. Please, we hope that there will be active engagement and questions during this webinar. You see at the bottom of your screen a Q&A button. Please tap on that and a box will come up. Please enter your questions in the Q&A button, in the Q&A box. And we encourage you to add questions. We will sort through the questions and we will pose them to the team. I want to now go over and introduce our first speaker. The run of our show today, we will first look at the question of why the study was done, and then how the team did the emotive research, how the research was conducted, and what were the findings? What did it show? And then there will be a really important presentation from the 4 participants or the 4 researchers who led each of the country teams for where the study was done. This will give us an opportunity to not only understand the result, but how we achieve the results. And then we will look at some next steps towards implementation and have question and answer. So without further discussion, let me go introduce our first speaker, who was the PI for this study. Ari Kumarasamy is professor of gynecology at the University of Birmingham in the UK. He's the director of the Tommy's National Center for Miscarriage Research and the founding director of WHO Collaborating Center for Global Women's Health at the University of Birmingham. He has led numerous national and international research studies and trials over the past 20 years, including 6 trials that have been published in the New England Journal and other landmark trials published in the Lancet. So this is another feather in Ari's cap, but another demonstration that the right team of researchers was really put in charge of this. Ari is the chief investigator for the emotive trial and led the team that conducted the research. In recognition of Ari's contribution to maternal health, he has recently been honored with the award of Officer of the Order of the British Empire by His Majesty King Charles III. So I turn it over to you now, Ari, to take us through the first questions of why the study was done and how it was done. Over to you, Ari.
Thank you so much, Jeff, and a very warm welcome to everyone to this webinar. Good morning, good afternoon, and good evening. I hope we break the internet. There are so many of you online at the moment, but please, only after the webinar has been completed. So let's move on to the next slide, please. So let's start with a question of why. Why did we do this trial? Next slide, please. As you will know, the first reason is that postpartum hemorrhage remains a huge problem. There are some 24 million women who have postpartum hemorrhages every year somewhere in the world. Now that translates to 1 every second. That's how common it is. About 15 million of these postpartum hemorrhages occur with vaginal birth and about 9 million with cesarean section. Postpartum hemorrhage also kills. We know that about 74,000 women die every year from postpartum hemorrhage. So that's 1 every 7 minutes. And what's really concerning is that the numbers are on the rise. It is predicted that there would be some 7,000 to 8,000 more postpartum hemorrhages by 2030. So things aren't getting better, and postpartum hemorrhage is killing women. So why is this the case? So let's go on to the next slide. So before we actually address the reasons for why this might be an issue, why things aren't improving, certainly at the level of facilities, let me put a question to you. So you see a basin there with some fake blood and some swabs, like what you might find at the end of a delivery. Now, what practitioners throughout the world would do is to estimate blood loss after childbirth, the amount of blood a woman might have lost after childbirth. And I would like to invite you to do that now with what's being given on the screen there. Can you visually estimate, like every practitioner out there is doing right now throughout the world, and make an estimate of what you think is the amount of blood loss that you are seeing in the basin there? You've got 5 options. If you could choose one, that would be amazing. So let me give you a few seconds to do that. Okay. Brilliant. Okay, so there we go. Can you all see that? I hope you can see that. I'm able to see it. So there are those who put down 200 mils at 9%, 400 mils, 36%, 600 mils, 34%, 800 mils, 12%, and 1,000 mils, 9%. Now you know that all of you can't be right. There is only one correct answer, and that is 600 mils. Now, this would be an amusing experiment, except when you realize that those of you who marked 200 mils or 400 mils haven't made a diagnosis of postpartum hemorrhage by the definition that postpartum hemorrhage is a blood loss of over 500 mils, right? So those who marked 200 mils and 400 mils, that represents 45%. So half of you would not be giving a treatment to this woman based on the estimation that you have made. So this, by the way, is very common. We've done this experiment time and time again, and the variation in the estimations is as stark as we have just demonstrated from the poll. So let's close this and move on to the next slide, please. Brilliant. So the first problem is that we are not good with diagnosing postpartum hemorrhage. We miss postpartum hemorrhages. We make the diagnosis late, and that's because we are not good with accurate estimation of blood loss using the current standard, which is visual estimation of blood loss. We wanted to quantify this problem. And so if we could go on to the next slide. And okay, next slide. Perfect. So to quantify the level of misdiagnosis, we had a brilliant data set from a trial called Champion Trial that took place in 10 countries with over 30,000 patients. And what this trial did was that it collected blood loss using a blood collection drape. So we knew very accurately how much blood a woman had lost. And that's what you see on the x-axis here. And on the y-axis, what you see is when a healthcare provider made a diagnosis of postpartum hemorrhage and treated the patient with a uterotonic. And what you see here is that for someone who's lost 500 to 600 mil, only 26% of those women were diagnosed and given a uterotonic. But even when somebody has lost a liter, you find that only 70% had been diagnosed as having had postpartum hemorrhage and been given a treatment. And the shaded area above the curve represents the missed diagnosis. And what we find is that in about 47% of cases, the diagnosis wasn't made. So these patients never saw the treatment for postpartum hemorrhage. So missing the diagnosis is a big problem. Next slide, please. Now, since then, we have demonstrated the same amount of missed diagnosis using the emotive data from the control sites. So we had about 150,000 patients. And again, we demonstrated postpartum hemorrhage isn't diagnosed in roughly half the women who bleed 500 mils or more. Next slide, please. So how can we put this right? So visual estimation isn't good. That means we need to provide an alternative that allows you to estimate blood loss accurately. So you can have basins, blood collectors like the ones that you've got in the picture there, or you could have other solutions like, say, a standardized cloth mat. The idea here is that a fully soaked mat represents a certain level of blood loss. Next slide, please. But the one that we chose to go with is the one that the world has the greatest experience with at the moment, and that is the calibrated drape. And I will tell you a bit about this in a moment, but the idea is that the drape is placed under the woman after she's given birth, and all the blood that she loses after childbirth goes into that funnel-shaped bag that you see at the bottom here, and all of the blood is collected here so that you can make an accurate reading of how much blood has been lost. So there are calibrations here that allow you to work out exactly how much blood has been lost. Next slide, please. So we decided to put the problem of delayed, missed, and inaccurate diagnosis using an objective measurement of blood loss. The other problems that we are often faced with in a facility are that even when the diagnosis is made, as Jeff rightly explained, the treatment isn't always given consistently. So one treatment is given, and then the healthcare provider might wait to see whether that has worked. And then the next treatment is given. And if that doesn't work, then we move on to the next treatment and so on. So that is the sequential approach to providing treatment. The problem with that is that the clock is ticking and the woman is bleeding. And when the clock is ticking and the blood is being lost, the woman is getting closer and closer to having a catastrophic outcome, because it is time that kills women when they bleed. So the proposal there is to use a bundle, and the exact bundle that we used, I will share with you in a moment. The third problem is that even when you diagnose postpartum hemorrhage accurately and provide your first response treatment very efficiently, very quickly, there would still be some women who would continue to bleed. And those women will need to be escalated very quickly to have definitive treatment, whether it's uterine tamponade or being taken to operating theater for definitive management. So a delay in escalation can also kill a woman. So these were the three challenges that emotive set out to address. Next slide, please. So here you see the sequential treatment as it is delivered commonly at the moment. And on the right-hand side here, you see the bundle. The bundle is called MOTIVE, and it's an acronym. So M is massage, so that is uterine massage. O is oxytocic drugs, so that is drugs like oxytocin and misoprostol. T is tranexamic acid. IV is intravenous fluids if the patient needs it. And the last E here is examination of the patient to identify the cause of bleeding and escalation of the care to the right setting. So this was the bundle. And as Jeff pointed out, it's an all or nothing phenomenon. If you trigger the bundle, then you give all components of the bundle. So massage, oxytocic drugs, tranexamic acid, intravenous fluid, and examination needs to be done. Even if the woman has stopped bleeding, you know, if you triggered the bundle, you do all of it. And that's the really important part of it. Okay, next slide, please. And the escalation criteria was very simple. These were the 4 criteria. If there was uncontrolled bleeding, if the blood loss had hit 1,000 mils or more, if the patient was shocked, or if there was extensive genital tract trauma, then you had to call in the most senior clinician available in that setting to attend to the patient. Next slide, please. So this is the current practice. Next slide, please. And what we try to do is to diminish the delays with diagnosis, first response treatment, and escalation. And that gave rise to emotive. Next slide, please. Now, having an intervention is all very well, but unless it's implemented with a degree of fidelity, it's not going to make any change. It won't bring any improvement in the outcomes. So we had to develop and deliver a robust implementation strategy, and that's what you see here. So we had a trolley or carry case that contained all the items that you needed to deliver emotive in one place. There was robust training delivered by Japaigo and partners. That was multi-professional on-site training with drills and so on. There were champions, both medical champions and midwifery champions, and there was robust audit and feedback system. So the sites knew how well they were doing and they could improve their practice. Next slide, please. So this was why we did it. But clearly, as Jeff pointed out, a good idea is great, but unless it improves the outcome, and we need to have the evidence to show that it improves the outcome, it is difficult to move that into policy and practice. So we needed to go and do a trial. And I would present this section on behalf of my colleague, Professor Yanis Gallos at the World Health Organization. Next slide, please. So I'll tell you how we did the trial. So it was a parallel cluster randomized trial in 4 countries. There was a baseline phase, and then half of the facilities, 40 of them, transitioned into emotive, and the other half remained in the usual care. Next slide, please. Now, what was important was that there was pilot work being done in totally separate health facilities to the trial sites, where we were able to fine-tune the intervention and the implementation strategy. So in every country, there were 3 sites totally separate to the trial sites, where the intervention was implemented, studied, and refined before it was brought into the 40 trial sites. And that's what you see there at the top left-hand corner. And then during the trial itself, there was important mixed methods work to understand how this intervention was being taken and was being used. And the work on that is being analyzed, and it would be presented in the future. Next slide, please. So looking at the specifics of the trial, the population were all women giving vaginal birth at the study facilities, the 80 facilities. The intervention is the emotive intervention, early detection, and the bundle treatment, along with the implementation strategy. And what's really important, so important that I've put this down in red there, is that every element of emotive intervention can be and was delivered by midwives, okay? So giving oxytocin drugs, giving tranexamic acid, giving intravenous fluids, and so on, were all delivered by midwives. Midwives are closest to the patient, and waiting for doctors can delay time, and ticking clock is what kills women. So we were keen that midwives were able to deliver all of the components, and that's how the intervention was constructed and delivered. The comparison was usual care, and the outcome was a composite of severe postpartum hemorrhage. So that's a blood loss over 1,000 mils. So that is 20% of the circulating volume. If a woman had lost 1,000 mils, nobody would argue that she's got an adverse outcome that needs to be taken seriously. And then the second component of the composite is a laparotomy for postpartum hemorrhage. And the third component was maternal death from postpartum hemorrhage. Okay, next slide, please. So let me just say a few words about the drape and how it was used. So you see the drape there, and you see the calibrations that can be found in the funnel. It had 2 lines. One was a warning line, and the other was an action line. And there were 3 trigger criteria, triggering the bundle of care. The first is that if the clinician has made a diagnosis of postpartum hemorrhage like they would normally do, then they can trigger the bundle, okay? They don't even need to look at what's in the drape and how much blood has been lost. If they diagnose PPH, they can trigger. The second trigger criteria is that if the woman has lost between 300 to 500 mils, and there is a clinical feature that concerns the healthcare provider. So she is tachycardic, hypertensive, looks unwell, and so on, then the bundle can be triggered. And the third trigger criteria is that even if the woman looks completely well clinically, if she's lost 500 mils or more, then the bundle was triggered. So there were 3 criteria. It was a little different in South Africa. In South Africa, there were 2 criteria. So that was clinical judgment or 500 mils or more. Next slide, please. We were really keen to have absolutely robust data. We had to be confident that the data that we are presenting to you is totally credible and valid. So what we did with the outcome assessment is that for every woman, after she'd given birth, after the blood loss has been collected, the drape was rolled up and placed on a scale like that, and a unique patient identifier was held in the frame of the photo, and a photo was taken, and this was uploaded in real time to our research portal. So every bit of data was source data verified. So we had CSDV, which is complete source data verification. Okay, next slide, please. And the trial took place in 4 countries. with 80 facilities. The unit of randomization was the cluster or the hospitals, but the unit of analysis were the women who'd given birth. Next slide, please. And it was a phenomenal effort, right? We had over 210,000 patients who were studied, randomized and studied in this trial. You can see all countries contributed. Nigeria had more sites and had contributed 83,000 patients. And you can also see that we captured almost all the vaginal births in these facilities, and we had pregnancy outcome data from 98%, which really is a testament to the team on the ground that delivered this trial. Next slide, please. So, having done the trial, it was completed and it was analyzed, and we got the results. And I would invite Professor Hadisa Galadansi from the University of Bayero to share the results. Hadisa.
Thank you very much, Ari, and a very good morning, afternoon, evening to all our participants. And I have the next slide, please. All right, very good. Now, it was very important for us right from the beginning to ensure that our sites, both our intervention sites and our control sites, were virtually the same, except for our outcome that we're looking for. So right from the beginning, we wanted to make sure that the factors that can affect postpartum hemorrhage were the same in our intervention sites as well as in our control sites, which were doing the usual care. Now, looking at the numbers of delivery, you can see that in our intervention, we had about 1,100 and we had about 1,200 in our usual care. Looking at the availability of the bundle components, which Professor Ari has just described, we had them all in our usual site as well as in our intervention site. Looking at the age of the women that delivered in our hospitals, they were all the same, 21 plus 26. 26 years was the years, the average years for the women in the intervention as well as in our control. Looking at the parity and the gestational age at delivery, they were all the same. In fact, even the previous cesarean section, we had 3% in the intervention, and we had also we had 3% in the intervention and we had 2.5 in the control. Multiple pregnancy, instrumental delivery, even antepartum hemorrhage. In antepartum hemorrhage, we had 0.1% in the intervention and we had 0.6 in our usual care. So our intervention site and our control sites were virtually the same. Next slide. Now, so after the the baseline, then we had the transition, and then we now had the actual trial, the randomization. At the end of the day, in our intervention site, we had 794 women that had severe blood loss, which is blood loss of 1,000 mils, which is severe postpartum hemorrhage. In our usual sites that were doing the usual sequential type of management, we had 2,139. Ladies and gentlemen, that is 60% reduction with our intervention. 60% reduction. Our risk ratio was 0.40. That's 60% reduction. In the intervention, we had only 1.6% of women having severe PPH. In our usual care, we had 4.3%. That was really an eye-opening for us. We didn't anticipate that we're going to get up to that 60%. We're looking for just about 20-25% reduction, but we got 60%. Next slide. Now, it was important for us to look, throughout the time, the duration of the trial. Did we have this difference, or was it just at a particular time? And you can see during the baseline, both our the percentages in terms of our control and our intervention sites in terms of our severe PPH were virtually at the same level. The red line is the control, while the green line is our intervention. So you can see the intervention at that time, it was almost 4% that we had for a severe postpartum hemorrhage. And the control had a little bit more than that, maybe 4.1, 4.2. But then when we started after the transition, you can see that immediately post-randomization, you can see that we maintained in the control the same percentage, going between probably 3.9 to about that 4.2. Of course, you know, when you're doing a trial, usually you get a bit of improvement in whatever you're looking at. So maybe that was why we had a little bit of a dip. But you can see in the intervention, you can see it went right down from that 4% right down to about 1.6%. So in fact, if we had continued with the trial, probably would have come to zero. So this really shows that, you know, right at the time when we started the randomization and the intervention, there was actually a reduction of severe postpartum hemorrhage. Next slide, please. All right. Now, so we said probably let's also look at other, you know, we had other outcomes. So especially the implementation outcomes. Wanted to find out how was the detection of postpartum hemorrhage? Remember the E in emotive is early detection. It was very obvious, you know, in our analysis that at the end of the day, we had 93.1% of the time severe postpartum hemorrhage was detected, while in our usual care, only 51% of the time. And Professor Ari said, you know, that was what even the champion data showed us and our own data. So in the intervention, we had 93.1% detection. In the control, we had only 51% detection, almost twice the amount of detection when you actually use the emotive bundle. Now, in terms of compliance with the bundle, of course, in the intervention, because it was an intervention and we're there doing the trial, we had 91% compliance. We know that even in research, somehow, you know, some people will just not comply, but we had up to 91% compliance. Of course, in the usual care, it's only some people that would think, okay, doing the bundle, because that's what the WHO said, maybe will really save the life of the woman. So only 19% of the time that, you know, in the control that the bundle was actually given, while in our intervention, 91% of the time we gave the intervention, the bundle. Next slide, please. Now, looking at other secondary outcomes, you know that postpartum hemorrhage, ordinary postpartum hemorrhage, not the severe postpartum hemorrhage, is 500 mils. And in this study, it also showed that, you know, in our intervention, there was a reduction of the postpartum hemorrhage, not even getting to the severe postpartum hemorrhage. So we had only 8.5% in our intervention, while we had 16.7% in our control. In fact, almost 50% reduction because our risk ratio was 0.51. Looking at, we've talked about the severe postpartum hemorrhage, which is 60% reduction with a risk ratio of 0.4. Looking at maternal mortality now, it's important to know that actually we didn't power the study to be able to show a reduction in maternal mortality. We only powered the study to be able to show a reduction in severe postpartum hemorrhage. But then data showed that there was almost 20% reduction in maternal mortality, sorry. We did not power the study to show a reduction in maternal mortality, but we powered it to show a reduction in postpartum hemorrhage. But then, as I said, there was a 20% reduction in maternal mortality. As you can see that the maternal mortality, there were 12 in our emotive and there were 18 in our usual care hospital. In terms of all costs of maternal mortality, which includes eclampsia and all the others, it was 17 in the emotive and it was 28 in the usual care, which is also a 30% reduction. In terms of blood transfusion, we also showed that there was almost maybe we can say 10-12% reduction because we had 2.2% in the intervention, and we had 2.6 in the usual care. But in fact, the blood transfusion for bleeding, we had only 1.2 in the intervention, and we had 1.9, which is almost 30% a reduction. Next slide. Now, we did subgroup analysis as well as sensitivity analysis, so that we'll make sure is there a difference between the different countries and so on. Now, emotive intervention was found to be effective in all the 4 countries, which is Nigeria, Kenya, South Africa, and Tanzania. And then also 5 types of sensitivity analysis were conducted, but none of them showed any difference. And when we adjusted, for baseline imbalances, there was no difference. Next slide. Now, Ari, are you going to take over from here?
Sure, I will do.
Okay.
Thank you so much, Hadiza.
Thank you.
Thank you so much. So we were looking for a 25% reduction in the composite primary outcome, and we found a phenomenal 60% reduction, right? Far more than what we had anticipated. Now, why is that? Well, when you look at the detection rate, what you see is that in the usual care shown in blue, as I mentioned earlier, we were missing about 50% of postpartum hemorrhages, but with a drape, with more accurate diagnosis, we are missing far fewer cases, less than 10%. So it is the fact that we are picking up so many more cases of postpartum hemorrhage meant that we were giving treatment to a lot more women. And obviously we had also improved in terms of the way that we were treating. Next slide, please. This benefit and this change was seen in every country, as you can see. The baseline was good in Tanzania, but even there was an improvement with the intervention. Next slide, please. And what you see here is that as Hadiza mentioned, the detection rate went from about 50% to over 90%, and the bundle compliance also went right up. And one of the other interesting findings is that the time to initiate all the components of the bundle in the emotive group was 13 minutes. So it's to start each one of the components of motive bundle. But in the usual care, it was 23 minutes. So in the usual care, it was more sequential, and in the emotive, it was being genuinely bundled. Next slide, please. So that is why we think emotive worked, and we are in the process of unpacking, and we would be able to give you more information. But you saw that tranexamic acid is an absolutely vital component of the bundle, but it is not always used in practice. So we would like to put this question to you, which is, have you administered IV TXA in your practice? So this is a question to the healthcare providers amongst you. If you could take 15 to 20 seconds to answer it, that would be amazing. Okay, brilliant. Next slide, please. Could I have the next slide? Excellent. And we were really keen to move on to country reflections to get an idea about how things really worked in each one of the countries. And the country team are absolutely the best people to share this with us. And I'm delighted that the PIs from each one of the country is online to provide an oversight about how it worked in each one of the countries. So we got Professor Sue Focus, Senior Lecturer Fadloon, Alwi Al-Beiti, Professor Zahida Qureshi, and Professor Hadiza Galadansi. Let me briefly introduce each one of the speakers. So Sue is a professor at the University of Cape Town. She is also a member of the National Committee for Confidential Inquiries into Maternal Death. And Sue was one of the co-PIs for emotive in South Africa. Fadloon is a senior lecturer at Muhimbili University in Dar es Salaam in Tanzania, and Fadloon has led several postpartum hemorrhage trials. in Tanzania. Zahida is a professor at the University of Nairobi and has participated in several postpartum hemorrhage prevention and treatment trials, including the Champion trial that I mentioned earlier. And Zahida also works very closely with the WHO. And you've heard from Hadiza already, who is a professor of ONG at the Bayero University in Kano, and is also the founding director of the World Bank supported African Center of Excellence in Population Health and Policy. I will ask Sue to get the presentations going. Next slide, please. Sue? Brilliant.
Okay, good afternoon, everyone. I hope you can hear me and see me. Good afternoon. Time zones. It was a great privilege for South Africa to be a part of this. This presentation is done on behalf are listed on this slide. And South Africa, we're right at the tip of Africa. So you can see in yellow on the map at the bottom where our sites were. Now, just to give you the context, before Emotive in South Africa, we had our confidential inquiry into maternal deaths. And although PPH was the second or third most common cause, it was the most preventable. And in fact, 89.5% of all our PPH deaths were preventable. And the confidential inquiry also identified delay in recognition, i.e. we weren't picking up PPH until about 1 or 1.5 liters, 2 liters had been lost. And that when it was picked up, it was done too little, the treatment was too little and too late. The blood loss in South Africa was always subject.
Sue, we're having quite a bit of trouble hearing you. You're cutting in and out. Others, I'm afraid we can't hear you. So maybe you can check your connection and we should move on to the next presenter if we can't get Sue back. So Zaida, can I ask you to jump in and then we'll see if we're able to get Sue back.
That's fine, thank you. So hello everybody, good day. It's really a pleasure for me to be here to present the reflections from Kenya on behalf of my team as are listed below. Next slide, please. So to just share with you what our burden is of maternal deaths and postpartum hemorrhage. Currently, we have a maternal mortality ratio of 362 per 100,000 live births, translating to about 6,000 maternal deaths every year. And from our confidential inquiries into maternal deaths, which was set up following the example of South Africa, from our first report and a bit of statistics after that, over a 4-year period from 2015 to 2018, it was noted that 38% of the maternal deaths were due to postpartum, due to obstetric hemorrhage, most of which was postpartum hemorrhage. So you see that for us as a country, it was very, very important and crucial and timely that we engaged in this trial, and it was a pleasure for us to be part of it. Next slide, please. So in our country, we had 14 sites, 7 intervention and 7 control sites, as you can see from the map, spread out right across the country from the left borders of Lake Victoria right to the shores of the Indian Ocean. Next slide, please. So we would like to share with you our experiences and lessons learned in our sites for the use of the trolleys and the carry cases. Next slide, please. So we had trolleys as the one shown on the left side with drawers and for those facilities that had space and for those that were space constrained. On the right, we have a carry case, which is like a toolbox. And these were availed to all the intervention sites, stocked with commodities for prompt response to PPH emergencies. For us on the left side, as you see above the trolley, we had displayed an action plan, which was showing us all the steps, and this was beneficial for the staff to manage a case of PPH. We ensured that the trolleys and the carry cases had all the supplies replenished soon after an event of postpartum hemorrhage resolved, and it was the task of the provider to ensure that they would maintain a checklist. Next slide, as shown in the slide, that we had a checklist with all the items listed on the left side with the amounts of these items, and every day the providers would actually go through and do a count of all these, and at the bottom would date and initial, so that there was ownership of maintaining all the commodities that were required. Next slide, please. So of course, there were always challenges that do come up, and how did we resolve this? So there used to be initially periodic stockouts of the commodities, and we helped and worked with the sites to strengthen their supply chain management and ensure that they would requisition these supplies in time. Initially, there was also inconsistent trolley handover. We worked with facilities to ensure that now the trolley was also sort of handed over during the handover of the shifts from one shift to another. And for sites that had a space constraint, as I mentioned earlier, we supplied them with the carry cases and not the trolleys. And some facilities had an issue with printing out the checklists on a weekly basis. So we advised them on how to use a hardcover counter book as a solution for them to maintain a list of the commodities. Next slide, please. So in Malindi, which we call the Innovation Hub, they decided to use a school bell, such as the one shown in this diagram, in this photo, which they would ring once whenever there was a postpartum hemorrhage. The staff would come running in, they would pick the trolley and wheel it to where the event was happening and be able to respond quickly. And as you've seen the quote, the PPH trolley optimized the team's ability to efficiently treat this event by reducing the time and distance travel to obtain the necessary materials. So we have then asked all the sites, and actually they took up this initiative. So this has worked very well. Next slide, please. It's just to share with you that we had the champions meeting for all the champions, the midwives and the doctor champions from the intervention facilities, and a lot of knowledge sharing and exchange of ideas and networking happened. So this was one of the success, the champions teamwork. So next slide. With that, I would like to thank you all for listening to me and for this presentation from Kenya. Thank you very much.
Thank you so much, Zahida. Before we have Fadloon share with us reflections from Tanzania, I wanted to share with you the findings of the poll. So we asked the question, how many of you administered TXA? It is an element, a core element of the emotive bundle. And this question was only put forward to the healthcare providers, and you said 50% of you use it in practice, 25% said no, and another 25% said it is out of scope of practice. So clearly, this is an area where there can be a lot of improvement, where a lot of improvement can be made. Thank you. So I would ask Fadloon to share with us the Tanzanian experience, please.
Good afternoon, everybody. It's a pleasure to be here. I'm Fadloon, and I'm working with Muhimbili University, and we implemented emotive in Tanzania. Next slide. Okay, so this is just a few pictures of my country. Next slide. Next slide. Okay, So in Tanzania, emotive, Tanzania has a maternal mortality. Tanzania has a maternal mortality rate of 238 per 100,000 live births. From MPD SARA review of last year, from 500 cases that were reviewed, 38% of them were because of postpartum hemorrhage. So emotive came at a very right time to help us work with postpartum hemorrhage. We implemented emotive trial in 14 trials with 3 adaptive sites. And the sites were around northern part of the country and the eastern part. Next slide. Okay. So from what we have had so far and from our experiences, we know that postpartum hemorrhage is very complex, and the burden of postpartum hemorrhage is caused with many issues around staffing not being adequate, supplies not being there, dynamics in the facilities, and so on and so forth. So when emotive came in with several strategies to help and assist that, it was really, really nice to see all these components, all these different strategies working together. Next slide. So my task was to present one lesson that we learned as a team, as a hub team, and the implementing team. And one of the things that I really want to reflect on is that there were a number of clinical practice changes that were introduced to make the trial work. And we all know that introducing something or a new practice is a process, sometimes long, sometimes short, but it's a process that requires hard work, commitment, and you need to train people, retrain them, support them, troubleshoot, and finding out from their own experiences what is working and what is not working so that you can improve on that. And for example, we had to introduce drapes very early on in the trial as an objective measure of blood loss. And to start with, the facilities, Tanzanian facilities, are already overwhelmed with number of patients and few providers. So when you're introducing a new practice of using a drape and following it up for an hour or two and taking it out and weighing it, that seemed like daunting. But because of the resilience and commitment of health workers on doing good, when they found out that this really helped them to have objective measurement, they adapted and used it, and it was quite a success. Next slide. Next slide. Okay. So another clinical practice change that we did as part of emotive was using a postpartum monitoring checklist. So this checklist, there are a lot of checklists, and we know every woman from delivery is supposed to be followed up for a couple of hours with regular examination and regular assessments. And there are a lot of tools out there in every labor ward. However, we know they are not being used. So as part of emotive, we introduced this checklist, and apart from the vital sign, it also had a component of assessing uterus tone and also assessing the blood, the flow and the amount, which was quite helpful. Initially, again, this was quite a daunting task for some of the facilities, but for the facilities which really embraced this and they thought this was quite nice, although they acknowledged that you cannot do it as frequent as it's supposed to, but somehow, even if you do it 2 times in 1 hour, it made a big difference and was embraced. Next slide. Another practice that was changed the atmosphere in the labor ward was the facility, the audits and feedback newsletters. So this was very important in that they used the data and provided feedback to providers, and they could say how many postpartum hemorrhage they had, how many handled, what successes and challenges, and they could go back and see with what were issues on that. So this really happened. Next slide. Next slide, please. Okay. So I think Zahida talked about champion meetings, and these were really nice and they really help in implementing the trial. Next slide. Next slide. I think that was my last slide.
Thank you. Thank you so much, Fadloon. Hadiza, would you be able to share the reflections from Nigeria, please?
Yes, please. I'm going to off my video just because of the network. In terms of Nigeria, unfortunately, Nigeria contributes now 28% of all global maternal mortality, and we have about 82,000 maternal deaths that occurred in 2020 in the current data released by the United Nations and WHO. So really, the issue of finding how we can reduce maternal mortality in Nigeria it's really a priority. The health system and everybody is trying to find how do we address this unacceptable, numbers of women that die. So emotive came at the right time because we're looking for options, and of course, maternal mortality as a result of PPH was the highest in terms of causes. And our experience actually is that it's quite common, because when we now started really looking at the numbers of women that actually have the PPH, then we found out that it's in fact commoner than what we think in terms of the postpartum hemorrhage, both the normal postpartum hemorrhage of just 500 ml and that of 1,000 ml. Now, we were in 40 health facilities, and we had the adaptive sites, and we had 39 intervention sites. And one of the first things in terms of experience is that adopting a new intervention is a challenge. The simple thing of putting a drape and, looking at the actual number or amount of blood loss was something that, because our healthcare workers were just used to estimation. So it was so difficult to just change that, that practice. So as all the other, country PIs said, it's really a problem to change practice. So you really have to be adamant and really have a strategy on how you can achieve a change of a practice, because it needs a change of a behavior, and changing of behavior is so difficult for human beings. So the first thing we realized that you need training, and you just don't train the research team. You need to train the whole staff in labor ward, because every patient in labor ward participates in the care of a pregnant woman when she comes in and develops PPH. So you needed to train the whole, staff in labor ward. And that was really a challenge. If you're doing a research and you just have 4 or 5 research staff in a center, then it's so simple to train them. But when you have to train 40 people, 50 people, starting from consultants to, registrars, to medical officers, to house officers, to students, everybody that is working in labor ward had to be trained. And then also you needed mentoring and supervision and feedback. And that mentoring and supervision was done by the champions. As Fadloon said, the champions were really useful in ensuring that, there's implementation of the trial of the intervention. And then of course, availability of all the items. If you tell people to give a bundle approach, that means you need oxytocin, you need probably misoprostol, you need tranexamic acid, you need IV fluids. It's not all our labor wards that have these items at the reach. Some of them you have to write for them to go to the pharmacy and buy. Some you have to even go outside, outside outside the hospital for you to be able to get the items. Next slide. I have just 2 slides, so next slide. So really, the healthcare, our experience was that once they started adopting, the intervention, they realized that it's really effective. And then we had no trouble getting them to adhere to it. Every single staff was really willing to continue to use the drip as well as use the intervention, because they saw that it was actually working. And then the women themselves, we had them talking to each other. They will be asking each other that, did they use that, that leather for you? Because if they use that leather for you, you're not going to bleed. So they sort of connected the use of the drape, and they're not bleeding, which was very important. And then another important thing is that the full staff in labor ward were thanking us because their labor ward was very clean, because no more blood on the floor. Every blood gets into the drape, and therefore no more blood in the on the floor. So the cleanliness of the labor ward was achieved with our emotive intervention. So really, all our sites, when we finished the trial, wanted to continue. They kept on asking us, why do they get the drape? How will they continue to get the drape? They want to continue to use the intervention. My last slide, please. Yes, ladies and gentlemen. So really, for you, the strategies to support in the implementation of emotive is training, the PPH trolley, the champions, and the feedback that Fadlum mentioned. Last slide. Yes, thank you very much.
Great. So we want to do another quick audience poll because we really want to hear from you. Please, on your screen, you see the poll. Please answer this question. Do you think nurses and midwives in your country are able, and are they authorized to give all the components of the bundle independently, initiating the bundle on their own? We'd love to see that poll. We also, I'm going to take Ari's going to come back in for a second, and we're going to do a quick discussion about, so here's the response. 74% think that nurses and midwives should be able to initiate the bundle. That's great. I think we have some work to do in some of the other settings, because we really, the world over, midwives are seen as providing BMOC services, BMOC interventions. And this is really within the scope of practice for midwives. So we need to think about what the barriers might be to administering the bundle. So I'm going to hand back over to Ari and ask him to describe a bit about the implementation and the next steps. And then I'd like to get to some questions. There are a number of really provocative questions in the Q&A. So Ari, quickly back over to you.
Brilliant. Thank you so much, Jeff. Next slide, please. So in terms of where we are heading next, clearly we provided the clinical effectiveness data. Now we need to provide the health economic analysis findings. So there is that being completed as we speak. We would also carry out budget impact analysis that would give an idea about what level of investment is needed in a typical country, for example. We need to carry out implementation research outside of the African context. So there is implementation research that will be conducted in Pakistan imminently. We are unpacking the emotive intervention through the analysis of the process evaluation research that we did. And we are working with policymakers world over to try to shift the evidence into policy and practice. Next slide, please. So in terms of what we need at international, national, and local level to make it happen, clearly we need clear guidance and policy at the international level, and hopefully WHO would look at the evidence and make appropriate recommendations. And then they would need to be translated into national guidelines. But really importantly, they would then need to be translated into local protocols. And so there is work to be done there. And then there is the need for a commitment for financing. I'm pretty sure that the health economic evaluation would show that emotive is a highly cost-effective intervention, but there would be some need for investment. Hopefully these would be made available. Now, what's really new here are the drapes. This is not the current standard of practice. So we need to see how we would provide a scalable solution for objective measurement of blood loss. DRAPE is what we used in the trial, but there are other innovations like a blood collection tray that could be used for this purpose too. So I think there is work to be done there. And then the PPH trolleys and carry cases, these are being used in many settings already, but we hope that, you know, the use would expand. Drugs are important, good quality drugs, and then obviously training, champions, audit and feedback. These were all important elements of emotive, and we would need to see how we would implement these in a meaningful and scalable and sustainable way. Next slide, please. So I just wanted to kind of share with you the exciting news about how there is so much ground up excitement about the DRAPE and the objective measurement of blood loss. You can't really contain a good idea. This, you know, people are seeing it for themselves. We need to measure blood loss. That's how we will know if somebody is having a postpartum hemorrhage. So what we have found, next slide, please, is that there are lots of ideas about DRAPE and other ways of measuring blood loss that is coming into research, development, and practice. Next slide, please. So this is what we used in the trial. This is excellent fixable DRAPE from India. It costed us something like $2.25 US per unit. Already has come down to 1.5, which is great, and is going to come down even further. Next slide, please. But there are so many innovations that are being proposed. Here is one. So there are two parts to this. There is the top part that the woman ties around her waist. This is reusable, breathable material. And then there is a plant-based plastic, which is biodegradable at the bottom. So this is one idea. This has been developed and is being trialed in Malindi as we speak at the moment. Next slide, please. There are other ideas and prototypes in development, and this is just to show you that this is all in hand. Next slide, please. But what is really heartening is that people aren't waiting for, you know, a global solutions to emerge. So this is the tailoring department at Malindi has produced their own DRAPE, as you can see, and the DRAPE collects all the blood, and this is produced using Macintosh, which is commonly available, and all the blood goes through there, and it actually comes out of the other end and goes into this basin. Now you can just about see this basin is calibrated, you know, so they have innovated and they are using this already. Next slide, please. And this is reusable, which is fantastic. And there is a 3-step disinfection process that they are using at the moment. Next slide, please. This is a Nigerian adaptation, and this is being trialed in Nigeria. Next slide, please. And Justice, who is on the line at the moment, has designed an interesting and important model that could be used. And the important thing about this is that it uses a reusable calibrated blood collector that you can see in the figure there. Next slide, please. But DRAPEs are not the only way to objectively measure blood loss. And this is being used, this is a tray that is being used in South Africa at the moment while they're waiting on the supply of DRAPEs. And this has got calibrated calibration. So again, the blood loss can be objectively quantified. And there is already work done to see how people like it, and the data are very favorable. Next slide, please. So yes, you can't really contain a good idea. People are running off with it, which is really amazing and heartening to see. Jeff?
Great, thanks very much, Ari. I think that addresses some of the questions that are in the Q&A box about the affordability of DRAPEs and measurement, et cetera. I encourage the research team to please take a look at the Q&A box and do some direct answers to some questions. But we will open it up for some other questions now. I would like to ask Justice to step in. Unfortunately, Sue has had some trouble with her line. Justice was also participating in the program in South Africa. Just a quick overview from South Africa, Justice, if you would.
Thank you so much, Jeff. And in addition to what's been noted from the other countries, which was similar in South Africa, we learned two important lessons from emotive on the ground. The first is that introducing the drapes was difficult at first. There was resistance to change, as Hadiza said. However, the emotive intervention with drapes is very intuitive. And once the sites had actually got over their resistance and introduced them, it became absolutely clear to all the clinicians, doctors and midwives, that this was the right way to go. They didn't need to wait till the end of the trial to believe that this is how they should be detecting and managing postpartum hemorrhage. So it's a very intuitive and positive feedback experience. And the other important thing, which was specific to South Africa, is that we had very, very limited professional research staff. Most of our research staff were non-professionals who could only document research outcomes. They could not contribute to the intervention. So what we were very pleased to see is that it was possible for this intervention to be implemented by the routine staff in the labor ward without assistance from professional research staff. And that's absolutely critical when it comes to implementing this intervention elsewhere in the world, where there will not be the luxury of professional research staff. Thanks so much. That's all I wanted to add from South Africa.
Brilliant. Thanks very much, Justice. So I would like to pose a couple of the questions to the researchers, and I'm going to start with you, Zaida. Maybe a question to you. A couple people have asked in the Q&A, what's the most important part of the bundle? And can we focus in on that most important component and just do that? What do you think about identifying the most important intervention in the bundle and only doing that?
I think it's a bundle, but if you ask me, the important part is, first of all, measuring the blood loss objectively and recognizing that you have a situation that you need to deal with. Because prior to that, we just make all sorts of very vague estimations. And then due to that, we missed treating a lot of women. So for a starter, I think for me, that's the first step.
Yeah, it was a little bit of a trick. It's a little bit of a trick question. The idea of a bundle is that you do everything. We had routine practice is doing only the components. And so you're absolutely right that a bundle is a bundle. So maybe a question to you, Ari. I think there are some questions about cesarean section, better estimation of blood loss in cesarean section, and also why cesarean section was excluded from the trial.
So I think we have similar issues with cesarean section. We know that cesarean section postpartum hemorrhages occur, and women die from postpartum hemorrhages at cesarean section. And so I think the problems of diagnosis are very much there intraoperatively, but also postoperatively when the woman is in the recovery area or in the postnatal ward. So I think we are in the process of developing solutions for that. How do you accurately measure blood loss at cesarean section, and what would be the right way to manage using perhaps a bundle and, provide effective treatment without going through the sequential pathway. For cesarean section, we think, again, a surgical drape would be very important to collect all the blood so that, we are not relying on visual estimation. But clearly also the vitals are also a marker of the amount of blood loss. And I think WHO has been leading a program of work on this, and I think there would be some important output on this imminent on this issue. But I think the problems are very much there for cesarean section, and I think we need to address it head on if we are going to make a substantial impact on reducing postpartum hemorrhage deaths.
Yeah, no, really critical. Maybe a question to you, Fadloon or Hadiza. A question about the availability of the drugs in the trial. I think we always set up a trial to make sure that we have the appropriate commodities, but commodities are a challenge. How have things changed as a result of the trial in the willingness of your facilities to ensure a good stock of quality drugs?
Fadlum, are you taking first? Fadlum?
Yes.
Go ahead.
Yes. So from the experience of emotive, facilities really learned the importance of having everything in place. We have a couple of facilities which stepped up, and before they didn't have tranexamic acid in their pharmacies, but now they have made sure that whenever they procure drugs, they have tranexamic acid. And there were also facilities which used to procure tranexamic acid for obstetrics, but once it comes to the facility, then surgeons and other people are using it. So now they have made a resolution that each department order their own drugs, and they say exactly how much they want, so that goes straight to that department, like labor ward and the likes. So there is a move. Even during the champion networking, this was really discussed, and those who were not ready to order were really made to know that it is quite important. We still had a challenge with health centers, which had a high number of deliveries. So we had a couple of health centers which had more than 500 deliveries a month. And even if they try to procure, usually this is not enough. So they still need assistance. The same with high-load hospitals. Hospitals with more than 400, 500 a month, they still need some support, but they are getting there because now this is very much talked about. Yeah.
Good for you, Fadlun. Don't let those surgeons take all of our tranexamic acid. You stand in the front door and you stop them from taking it. Hadisa.
Yeah, I think what I want to add to what Fadlum said is that actually we tested all the oxytocin because, we have a challenge of quality of oxytocin. But we tested for both the control and the intervention. And we found out that some of the oxytocins were of very poor quality. So at the end of the day, we brought out the oxytocin brands that were of good quality. And all our sites, the control and the intervention, had to be using the good quality oxytocin. We had to make sure that also the control sites were using the good quality oxytocin. And because of that, the sites have now changed their policy of getting the right type of oxytocin. So I think Emotive has done that. Even if you don't, get the intervention, at least now we're using, good quality oxytocin. Yes, there's challenges. Some of the hospitals, they don't have all these drugs in the labor ward. They might have them in the pharmacy, but we made sure now that they have everything in the labor ward, and it has become a practice. So we wrote letters to their managers to tell them how important it is, and they've carried it over, done advocacy, and now the management is actually providing the drugs for them. So I think it's just, advocacy, commitment, lobbying that will make sure that these things are in the right.
That's really important, Hadisa, and I think it raises another point that I'd like Ari to come in on. I think we've always talked about postpartum hemorrhage as being the #1 cause of maternal mortality. Postpartum hemorrhage is a problem, but we often don't talk about it as the emergency that it is. And I loved the picture from Zaida of the bell and kind of like changing the tone and the attitude on the labor ward for responding more urgently. But I want to ask you about the threshold for response. Where did this number of 500 mLs come from? And should we really be using a threshold of 500 mLs to act? Or as the Tanzania team did, act a little bit sooner if there are other mitigating factors?
Thank you, Jeff. Postpartum hemorrhage is a medical emergency. It needs to be framed in that way. It means that you have to act very fast. And I keep mentioning it's the ticking of time that kills women. And I think that is to emphasize that whatever you do, you need to do it very quickly. And I think that's what saves women's life. I think the 500 mil, a nice rounded number comes from convention. We know that, there isn't a profoundly important biological or clinical reason why 500 is the right number. to get action going. And one of the things that we found, and this is one of the questions I see that has been also put forward, is why is it that postpartum hemorrhage rate itself has been shown to be reduced with emotive, right? So why is it that 500 ml blood loss, there are fewer of them? In fact, there are half. We have halved postpartum hemorrhage, blood loss defined as more than 500 mils, on the emotive side. The reason is that in every country, and this includes South Africa, people were treating women earlier than before they got to the 500 mil threshold. So they were treating at 300, they were treating at 350, they were treating women at 400 and so on. And this makes sense to me. If somebody is bleeding, you want to get in there as early as you can, and that would give you the best chance, especially if she's anemic, especially if you think she has a diminished circulating volume because she has a small frame, then you want to get in there sooner than later. And we found that emotive intervention in every country, healthcare providers, when they knew there was a problem, they were quick to get on top of it, and they treated at 300 mils, 350, 400 mils, and so on. And I think this is a discussion that needs to be had. What is the right threshold? Particularly in settings where there is anemia, you could very legitimately ask the question, is it really right to wait until 500 mils?
Right. So yeah, George Guaco in the chat asked a very good and provocative question. With these new developments, with these results, is it time to redefine postpartum hemorrhage? And I think this is something for this community to really start discussing and considering. Maybe we are waiting too long to respond to PPH. Maybe we are not treating it like the emergency that it is. So I'd like to there have been a number of questions about, and Zaida, I'd like you to respond here if you can. There are a number of questions about the first E. When do we estimate? A number of people who have said, how do we make sure we're not mixing amniotic fluid in the collection bag? How do we make sure that women can adopt the position of choice if we're telling them they have to be on a collection bag? Maybe you could clarify for people when the drape is used and how there isn't a mixture of blood and amniotic fluid.
Okay, thank you, Jeff. So I have actually tried to answer a lot of those questions live, but just to take you through. So this drape is actually placed under the buttocks of the woman, but not rolled out. So we wait for the woman to go into, nearing second stage, all the cleaning, the disinfectants that are to be used have been used there, and then the baby is born. So most of the amniotic fluid will be, expelled at the time of the delivery of the baby. And once the baby is born is when now we roll out the drape from beneath her bottom into, this hanging position. Or even if it's a flat bed, we just roll it out. Now from there, it's just blood, or almost all blood, that's going to come in and be, going into this drape. If a woman has a postpartum, and we would like to keep it there, and for the sake of the study, for 1 hour, and a lot of you have asked what happens, to breastfeeding. The woman can breastfeed, there is no issue with that. In fact, she can even sit up on the bed and hold the baby and continue to feed the baby, breastfeed the baby as the blood continues to trickle into the drape. If there is a postpartum hemorrhage, of course, she will not be able to do all that. We were also asked questions as to what happens to the swabs that you use for suturing. Our advice was to just not use the very large gauze pieces, but just small drapes. And we had weighed them, we knew their weight, and then that was put into the drape. But if if a woman is having postpartum hemorrhage, and then we would, of course, need to catheterize her as part of our management for postpartum hemorrhage, so we would not have that urine go into the drape. And if she really had to move out because there was a need to use that delivery bed for another patient who is about to deliver, then it was still possible, because this is tied onto her waist, with research staff, or with the hospital staff assisting the woman to actually get off, and the drape being held such, or if she was moved from the bed onto a trolley and then onto another bed, it was still possible. So of course, later as we are doing implementation, we'll see how this thing works on a real-time basis outside of study procedures, but all that was possible. So
Yeah.
I know if you have used it, it seems very strange as to how all these things happen. But those of us who have used it for a long time, starting from the Champion trial, it is a fairly, it's a very friendly, let me say, it's a friendly commodity to use. Thank you.
That's really excellent. We're down to the time, and so I just wanted to do a last question, a last poll for people, because I think there have been a number of really good questions in the Q&A section, and we're going to. I want everyone to go to this poll, this Menti on your screen, tap that QR code and go to the Menti on your screen. We're going to be summarizing and responding to all of the questions that are in the chat, and we will produce a summarized document with the responses, and we'll include that in a link to the presentation that will be sent out by the COP. But please go to this Menti poll, and we'll create a bit of a word cloud. The poll is really asking the question, what do you think, what do you need, what do you think it will be important to have the emotive intervention work in your country? How do we make sure that we can achieve scale with this? Because that's when we're going to achieve impact, when we really expand and we achieve scale. So please go to this Menti, take a look at it. It will be live for a few minutes even after we close the webinar, but please take a look. The other thing I think I wanted to respond to was there are a number of observations and questions in the Q&A about the drape, the maternal well tray. And so I just want to say that there will be a lot of energy going towards understanding this question. Sanapi Biomedical, which is a biomedical supply group in South Africa, is looking at adaptations to the drape, to the tray, to a variety of different things, and then also creating a supply chain for making these available. So I think that is an issue that people are going to be working on and addressing in the coming months. So I think this community of practice is going to be a great vehicle for helping to share updates when new resources are made available. So please take a look keep an eye on the community of practice and what they're doing. So again, we ask you to respond to this. Maybe we can share the responses offline as well, but these are some of the responses that we're seeing. Behavior change, leadership. I love the word speed. We need to change our frame of thinking about PPH as an emergency. We need to get a bell in every labor unit so that we sound the alarm. We need to sound the alarm for PPH. So again, thank you to not only the presenters for their presentation today, but thank you to the presenters and the research team for the incredible new knowledge that they have demonstrated and shared with the world. This is what we need in order to tackle postpartum hemorrhage and maternal mortality. We need new ideas, new knowledge, and then we need to apply that knowledge in our environments. So thank you again to everybody for tuning in. Tell your friends to sign up for the PPH community of practice, because it's only together and sharing experience and communicating that we actually will address postpartum hemorrhage. Thanks, everybody. Thanks for joining. Thanks to all the presenters. Have a fantastic rest of your day, and go out there and really talk about this. Bring your friends along. Be the champion. Take care. Bye-bye.